Welcome to this afternoon session about the potential of AI in predicting dementia. Maybe I should also say the limitations of AI, but I don't know if we make it so far today. We want to introduce you to the AI Mind project, which is a research and innovation action funded by the European Horizon program. I want to underline it is not thought to be a research action, it is a research and innovation action outside health. And why is that like this? And because the European community is lacking algorithm development. It is mainly dominated by the Chinese and by the American experts. And we will go into depth by several of our speakers from the AI Mind project, who all will introduce their part of the development of AI predicting diagnostic tools. And I will start introducing you to AI Mind. And as I mentioned already, it is thought to be a tool accessing mild cognitive impaired citizens in Europe and to select those who are really at risk. My disclosure is that I'm also a shareholder of the company BrainSynth, which is in fact also a partner in the AI Mind project. And I am as well associated to Eli Lilly. The facts, one more time, are that of the 100% mild cognitive impaired citizens, only, and I underline, only 50% are in fact of risk to develop dementia. This is important to mention because mainly in the public there is no hope ideology that all kinds of mild cognitive impairment would lead to dementia. This is not the case. And of those affected of mild cognitive impairment at risk, we know as well that again around 40% could have been prevented if we would have known early enough. And this is very concerning because there is no screening tool and there is no timely diagnosis. And it is almost that we are all awaiting, that we are confirming that a mild cognitive impaired citizen is developing dementia. And then we are satisfied, in a sense, and say, okay, now you have a diagnosis. And that is, of course, from a medical point of view, contradictory. We should know as early as possible to prevent further development into dementia. There are many aspects. We know that this has something to do with stigmatization and so on and so on. Nobody wants to talk about it, and you hide your symptoms maybe as well actively. And we have heard in many other lectures during the day, yesterday and also today, that in fact the percentage of diagnosed dementia cases which come for the first time to the healthcare system is pretty high in all our European countries. And in fact, it is, as you know maybe better than me from the Lancet publication, that it takes still 5 to 8 years to be diagnosed. And of course, we want to change this, and we claim that AI Mind will be able that you get a risk analysis within a week if you are affected by mild cognitive impaired symptoms. And how do we do this? First of all, we approach to get access to participants, to citizens, without having contact to the healthcare system. We know that from other studies, fingers and so on, that self-screening is pretty efficiently. You do not need necessarily the general practitioner. You need to self-screen you. And we were pretty much aware of this possibility and did so. So we digitalized completely our diagnostics. We made it available. I will come back to it. We automated then all kinds of efforts the general practitioner in the future could do. And then we introduced to this automation, we introduced then supportive AI. And that we are doing by first algorithm, which is analyzing the functional brain network you have. Mainly this is done, it's not a new technology. It existed for over 20 years, or 25 years now, but it was never available for patients. It was available in research and mainly in the business of fMRI. We adapted these technologies to EEG, and we are using, and that was new, deep learning algorithms and classical machine learning, because when we wrote the application, we feared that the resistance against deep learning would be bigger than expected. When we have this information of functional brain networks, we add on information about your genetics and your protein level of different kind from plasma or full blood. And we are adding digitalized cognitive tests. This is unfortunate, still not the case or not available at all hospitals worldwide, and as well not in Europe. We think that there is a political resistance against it, and it's a professional interest not to digitalize. And I say so because I think it is the time to provocate these new psychological community. Because you can't say that you have a bottleneck called neuropsychologist, and then you are waiting and waiting and waiting until it is too late. You should select those people who have to be investigated, particularly by a neuropsychologist, earlier than today. But not everyone needs a neuropsychologist. You have to select the right patient. And how do we do this? As I mentioned, by QR codes. And we were surprised. Most of the citizens today in Europe use QR codes, at least since they ordered in restaurants their dishes during COVID. So nobody has so much against QR codes. Then they could self-screen themselves. And if you fulfilled a certain threshold, then you had been invited either to your general practitioner, to your memory clinic, or to the AirMind Polyclinic. And when you were there, we then either had to include or exclude you. Of course, we couldn't include in this study already demented participants. And we could also not include too easy light subjective cognitive impaired people, because we are in the period of algorithm development. That will be different later. I will come back to it. And then as well, the doctors and neuropsychologists and so on who participated in the study as a person, as employees, they followed as well these QR codes for what they had to ask or when they had to ask. And certainly we had everything on one server in one country from all of the participating European countries. So it was a completely digitalized, harmonized European workflow. It is an automated data transfer, 24 hours. It gives us transparent information about what has been done, and it will be documented in a transparent way so that everybody later on our infrastructure can read and find on the European eBrains infrastructure, can find how we developed those algorithms. And at the same time, we could guarantee complete personal privacy. Why is that like this? Because our SSD server, who is taking or gathering all data, is completely closed. and not accessible. It's only accessible if on demand, and you will never be able as a researcher to leave this secure area with data. You are only allowed with your research data results after approval to come outside the wall. And why is this important? Because if the Europeans want to develop algorithm, then they have to follow the medical device regulations in the EU, which are new and which include today AI algorithms. And then a notifying body is coming and asking you, what have you done? How have you done it? Which data did you use? Did you respect European ethical rights? And so on. So you have to be able to document your research if that should lead to innovation. Later today in this session, Robin will talk about also the HTA, the Health Technology Assessment tool, which we developed, because it is far from sure that our tool is really of the benefit of the society. That has to be proven. And before hospitals would buy or will buy algorithm, I would certainly recommend that those hospitals are critically asking if that is really in the benefit. It could be disease specific, it could be country specific, when and where an algorithm should be used and when it should be forbidden. I'm so clear that there might be also algorithm which should be forbidden. And the cost estimation question is also under-communicated because the costs are also energy costs. And we never heat our AI mind offices because our algorithms are so energy thirsty that we never heat the rooms any longer. So very important was that AI Mind became also very quickly a part of a bigger initiative called eBrain Health, because when we develop our algorithm within our participating European countries, then it is very sure that it is only a correct algorithm for the particular cohort we are investigating. It could be very different in Hungary or Ireland or whatever country which has not participated. To make it, algorithm can be adapted, and to make our algorithm more generalizable, we have to give access to other cohorts. And that has to be prepared, and that will be prepared. So the end of the story, I guess, is that we will become hopefully a reference data bank, which is coexisting, collecting, expanding, and then that as many as possible countries will try to test our algorithm on their data. And why are we doing it? Yes, I'm coming back to it. We want to make it possible to predict risk estimation with introducing early personalized intervention. That is the whole point, because not each patient is like another. And personalized medicine will only be applicable and available if you are introducing AI technologies and simulation technologies in our healthcare system. And then at the end, we can tell you within a week, and then you should be offered your personalized intervention. So now I'm finalizing my little introduction, and then the employees of AI Mind are continuing. And first, Ina will talk a little bit about data quality and standardization, maybe. And then we are opening for a discussion at the end, because it's everything about AI Mind. Thank you.